Welcome to today's session, which was developed by MedIQ and supported by an educational grant from BridgeBio. I'm Robin Lynch, your moderator. Today we'll be discussing unmet needs in the management of ATTR-CM, along with exciting research updates on ATTR-CM treatment presented recently at the American College of Cardiology annual meeting. And now I would like to introduce our presenters, Dr. Michelle Kittleson, a professor of medicine at Cedars-Sinai and director of education in the heart failure and transplantation at the Smith Heart Institute at Cedars-Sinai, and Dr. Ahmad Masri, a cardiomyopathy section head, director of the Hypertrophic Cardiomyopathy Center and Cardiac Amyloidosis Program, and associate professor of medicine at Oregon Health and Science University. Welcome, Dr. Kittleson and Dr. Masri. Let's begin.
Oh my gosh, I'm so excited to be here, and I'm going to take faith that you can actually hear me right now. So that I love it when technology works. So our goal is to discuss unmet needs in the management of ATTR-CM and discuss updates and treatment study results with practical implications from the ACC 2026 conference. So I'm going to start with a few 2 minutes of level setting. As we all know, ATTR-CM is a condition where there's a protein the body produces naturally, transthyretin, but that for reasons we don't understand, in older age decides to deposit into the heart, causing a restrictive cardiomyopathy with heart failure symptoms. It is not rare, it is under-recognized. We know that in older individuals who are thought to have heart failure with preserved ejection fraction, or those who have aortic stenosis undergoing transcatheter intervention, roughly 15% tend to have ATTR-CM either underlying or concomitant. We know that the prognosis has dramatically changed over the last decade. It has gone from a death sentence to a chronic manageable condition through early recognition and diagnosis and disease modifying therapies that we'll talk about. So that currently the survival of treated patients approaches that of patients of the same age who don't have cardiac amyloidosis. So it's so important to focus on early recognition, early diagnosis, early treatment, particularly because currently available disease modifying therapies do not reverse disease, they simply slow progression. So I'm going to now punt it over to my awesome partner in crime, Dr. Masri, to tell you about his favorite studies from ACC, and then we'll hear about mine. Dr. Masri, take it away.
Thank you, Dr. Kittleson, and happy to be back here and joining you in this interaction. And so, at ACC, there were lots of things that have been discussed in terms of cardiomyopathies in general. Here, we're gonna just have few takeaways from some of the studies that we looked through. The first one that I'll cover is the long-term durability of acoramidis in transthyretin amyloid cardiomyopathy. As all of you are aware, ATTRibute-CM was a phase 3 clinical trial that compared acoramidis versus placebo in patients with transthyretin amyloid cardiomyopathy. It led to the approval of acoramidis in the United States as well as many other countries for the treatment of such patients. And so these patients who were in the original trial were offered continuous participation in an open label phase extension that is ongoing. And we get data from that. And I think that data that come from it help us understand more or less the longer term outcomes and the longer term changes that happen to these patients. And so this is a report that was presented by Prem Soman from the University of Pittsburgh as a late breaker, as well as got published simultaneously in JAMA Cardiology journal. So you can refer to the paper if you need to. And in that paper, out of 632 patients who were randomized to get acoramidis or placebo, it was 2-to-1 randomization. These participants, 389 of them rolled over to the open label extension. And so at that point in time, everyone was getting acoramidis, either as continuous acoramidis or transitioning from placebo to acoramidis. And the takeaway from the study is that the treatment effect that you see continued to actually accrue over time in the continuous acoramidis treated arm, while potentially or more likely that the placebo arm still got some benefit from acoramidis. You can see that there's still separation between the outcomes of these two groups, which drives home the message again, which I think is, from my perspective, one of the most important messages here, is that the earlier you recognize people to have the disease and the earlier you institute therapy, the more likely that you're going to benefit these patients because you can't easily reverse the disease. The other takeaway is that the effect of acoramidis on N-terminal proBNP, which is a surrogate of disease severity for TTR, as well as its effect on serum transthyretin, which is a surrogate for stabilization capability of acoramidis, everything has really been stable throughout the follow-up out to that 54 months. So this is not kind of just an acute finding in the primary trial. This extends now to the follow-up trial. So that essentially is the study, and some of the primary takeaways from it. It also just to close the loop there, it also showed that this effect size that you've observed in the primary trial continued to be substantial even in the longer term follow-up duration of that trial. So that was one of the studies and topics that we wanted to cover and highlight. The second one had to do with Vitruviran, where it's always intriguing, and the reason why I'm covering this is that relationship between amyloid deposition in the heart, structural changes on echocardiography or cardiac MRI, and treatment effect of the various drugs we use. This happens to be Vitruviran post hoc analysis from Helios B trial, which was Vitruviran versus placebo, and these patients underwent echocardiography. And in this analysis, it was looked at what happens to patients with various degrees of diastolic dysfunction. As we know, amyloid causes a restrictive cardiomyopathy, it causes restrictive disease and diastolic dysfunction. And as such, is the question, if you have more advanced degree of structural change, does that modulate your benefit from Vutrisiran here or any other of these other medications? And so the answer is really not, which I think is somewhat expected, because if you take care of these patients, you realize that there is these two distinct phases of the disease. They're related, but they're still not exactly the same. One is the deposition state, where you start to have structural changes in the heart, things are changing, but some patients are totally asymptomatic, even though they have a 2 centimeter ventricle thickness. While you have the heart failure state, which is where patients really start to develop that syndrome of inability to meet the body's demand when it comes to the left ventricular and right ventricular function there, as well as intracardiac pressures. And so that's exactly the reason why I wanted to highlight that, is don't think of treating patients within the framework of how is advanced their structural changes on imaging. It's more or less actually of how they're doing. Do they qualify? Are they too far advanced or not? Clinically, I think that's what's more important in that scenario. And then finally, to touch base on something that I thought was interesting, which is related to acoramidis attribute trial. When you use a stabilizer such as acoramidis or tafamidis, in this scenario it's acoramidis, your serum transthyretin level, which is the same as serum prealbumin, goes up in response to the improved stabilization. In this analysis, the authors worked on trying to show how that change in serum TTR can relate to how the patients feel clinically using Kansas City Cardiomyopathy Questionnaire. You were trying to relate a biological variable with a clinical patient-reported outcome variable, which always is difficult because of that variability. But interestingly, in this analysis, the authors are showing here that you actually do have a reasonable in a way, almost dose response relationship between the change in serum TTR and the benefit as perceived by patients on KCCQ. And the higher your TTR level and the higher the change level is, the more benefit that you're derived. This is one of the first evidence that we've seen, which builds on the other pieces of evidence that's seen from attribute, that this actually marker does matter. And it's not just a yes and no marker, increase or no increase. It does seem like there is a continuous relationship, that the higher your response in terms of stabilization, potentially the better the outcomes, either patient perceived outcomes or actual heart failure outcomes and death, which was shown in other analysis. I'll stop here. I'll turn it over to my partner, Dr. Kittleson, to see what she would like to highlight from ACC.
Amazing. I learn so much every time I hear from Dr. Masri. So he highlighted studies that focused on two of the available medications, acoramidis, which is one of the TTR stabilizers, keeps the TTR protein in its happy, stable tetramer form, so it doesn't destabilize, form fibrils, and go into tissue. And vutrisiran, which is a silencer, which acts on the mRNA in the liver, so it silences protein production. And there's a third one out there, of course, the first one, tafamidis, which is another stabilizer. So you've got the stabilizers, tafamidis, acoramidis, you've got the silencer, vutrisiran. The first study I want to talk about actually relates a bit to what Dr. Masri was talking about, which is you don't want to assume just based on non-clinical parameters alone that someone's too far gone to get treatment. And one of the parameters that should not be used solely in isolation to guide initiation of therapy is age. So there was a fascinating abstract presented at the ACC meeting: mortality in octogenarian patients with transthyretin amyloidosis treated with tafamidis, a systematic review and meta-analysis. So what did the authors do? They did a great job trolling through all the places where literature is cited, looking for studies comparing tafamidis versus control in patients 80 or above. This is a disease of older people to begin with. And in so many forms of medicine, we tend to do less when someone's over 80. Do we really need primary prevention statins? Do you have to do a colonoscopy? But this is a disease of older people, and we want to preserve good quality of life as long as possible. So should we use age alone as a reason not to give someone disease-modifying therapy for ATTR-CM? Well, in this study of 1,800 patients with follow-up from 4 to 7.5 years, patients above 80, tafamidis was associated with a significant reduction in all-cause mortality, 50% reduction. So what does this tell you? It tells you trust your clinical instincts rather than a single parameter. If you have a functional 85-year-old person who is diagnosed with ATTR-CM, there's no reason to withhold disease-modifying therapy. On the other hand, you have a 78-year-old patient who very sadly has advanced dementia or cardiogenic shock. They may not be the type of person who will derive the benefit we expect from preservation of quality of life, reduction in hospitalizations, or increase in survival. So that's the first one I wanted to talk about. The second study is about guideline-directed medical therapy. So guideline-directed medical therapy is fascinating, isn't it? Because we know, everyone knows, heart failure with reduced ejection fraction, give your patient the 4 pillars. Give them the angiotensin receptor neprilysin inhibitor as first line, followed by, if they can't tolerate that, ACE inhibitor or ARB, plus the evidence-based beta blocker, plus the mineralocorticoid antagonist, plus the SGLT2 inhibitor. But we have to think a bit differently in ATTR-CM. We have to be individualized because of the restrictive physiology. Because of restrictive physiology, these patients have a fixed stroke volume, which has 2 consequences. First, they rely on their heart rate to maintain their cardiac output. And as such, patients will likely not tolerate a lot of beta blockade to reduce the compensatory tachycardia to maintain their cardiac output. And beta blockers may result in a lot of exertional intolerance. The second consequence of a fixed stroke volume is if you attempt afterload reduction, vasodilation, they can't increase their stroke volume in response to afterload reduction to maintain or improve their cardiac output, and they may result in hypotension, tachycardia, acute kidney injury, orthostasis in response. So it's very important to be mindful of these potential consequences. So if a patient on all 4 pillars with an EF of 40% comes to you and says, oh my gosh, I feel so much worse since my beta blocker was upped, low threshold to back it down to improve quality of life, unless, of course, you need it for rate control of AFib, but then the minimal effective dose. Or if they come to you and say, gosh, ever since this sacubitril valsartan was started, I faint every time I stand up. Okay, low threshold to back off until their symptoms of orthostasis get better. So that is just a really big overview into this trial, which took patients with ATTR-CM and an international database with heart failure, and they said, how do people do when they're on GDMT versus no GDMT? And what they found is that on GDMT, tafamidis worked. It reduced mortality and hospitalization. And in patients on GDMT, there appeared to be some potential additional mortality benefit at 3 years. So, what's my takeaway from this? My takeaway is this: you should do based on your best efforts to implement guideline directed medical therapy. If their ejection fraction is above 40 or 50%, SGLT2 and MRA. In fact, those are very well tolerated with evidence they relieve congestion in patients with amyloidosis. But have caution for your ARNI, ACE-ARB, and your beta blocker, meaning if they are on them and they tolerate it, feel very happy about that, and maybe they're a form of on the spectrum of amyloidosis where they don't have such severe restrictive physiology, but have a low threshold. Empower yourself to prioritize quality of life if there's exertional intolerance suggesting too much beta blocker, or orthostasis suggesting too much vasodilator. So I like the fact that that study tells us if they tolerate it, great, but if they don't, they might be in this different subset of patients. So those are the two trials I wanted to talk about. We still have a few minutes left, so if there are any questions from the audience, Robin will alert us. But until then, I have plenty for Dr. Masri to pick his brain, and I'm sure vice versa. So, Dr. Masri, I really thought the results about serum TTR levels and clinical events is fascinating. So, if you give a stabilizer, one surrogate marker of good stabilization is your serum TTR level, which of course is the same as prealbumin, so pretty easy to check. And clearly there's a correlation that the more stabilization you have, the better you feel and do. But here's my question to you. When you have something like rosuvastatin, I can titrate it to LDL. Of course, I obsess about the LDL cholesterol because that is my therapeutic target. Currently, there's a one size fits all dosing for these TTR stabilizers. So how can I interpret those results? I can't increase the dose. So tell me how a serum TTR level is helpful in clinical practice.
That's a great point, and that's a good analogy with LDL and with rosuvastatin. I think with serum TTR and or serum prealbumin and amyloid, we might be in the 1980s when it comes to statins and lipids and how we approach this, because I think this is the starting point. It's just trying to provide evidence that this pharmacodynamic marker. So you're giving a drug that stabilizes TTR, and so you're expecting to see the TTR level go up. The question is, when it goes up, is there evidence that this is a good thing or not? And this is actually, even though we've been using stabilizers for a long time, I think these last few analyses from Attribute are the first kind of group of studies that have shown that this matters. So that we know now the answer to that. If you give a stabilizer and TTR levels go up, it looks like it matters. Now, the second question becomes, what if those don't go up? And what if, as you mentioned, could there be a dose response mechanism? Do some patients need more of one drug versus the other? Interestingly, this was shown with the tafamidis 2 formulations. And so some of you might be aware that there used to be Vyndaqel and Vyndamax. Vyndamax is the 61 milligram daily, which is equivalent of 80 milligrams of the Vyndaqel, while the Vyndaqel, there was a 20 milligram formulation that the VA used to use. Long story short, in the clinical trial, the 20 milligram resulted in less stabilization or less elevation of serum TTR than the 80 milligram, but that was never shown to translate, at least not never shown, but that wasn't published on subsequently to show that there is a differential effect necessarily in outcomes. And so that all is to say is that we're starting here with this. And so what we are trying to study in the next step, what if I give you a stabilizer and the serum TTR does not budge at all? You start at 18 or 20 and you stay at 18 or 20 on a stabilizer. Does that mean that you're a non-responder? Should I switch the treatment? Should I consider other treatments? We absolutely have no answers to any of these questions, but I think that's where this is heading. And for me personally, clinically, I am using it in order to start and study this and observe how patients are doing. So, we check it serially, and if someone comes back and says, what, I don't think I actually I'm benefiting from the drug that you're giving me whatsoever, we reiterate that the process is to prevent you from getting worse, not to make you feel better. But at the same time, it's intriguing then to look at serum TTR and see where things stand. And it's going to get complicated because with the silencer drugs coming along, they lower TTR, correct? And so, how do you essentially, incorporate that into that decision making? We're not ready to use it clinically. I don't think we are ready to make decisions based on it. But I think over the next few years, it appears to be a useful marker, and we should continue to build on our understanding of response or lack of response using this marker.
Well, you convinced me. I'm not going to make this super controversial and disagree because I agree with everything you said. It is a research tool, and in prospective registries or some sort of a way to gather lots of data to figure out how it will change management will be super exciting. And now, I'll tell you what I think about the answer to this question. But you mentioned stabilizer silencer. Tell me, how do you decide for a newly diagnosed patient sitting in front of you at clinic what you're going to give them?
Yeah, that's another good question, and I think right now at this stage we are in a way presenting the options and using the differences between the routes of administration, between the properties of the drugs themselves, and the evidence that's been published on them, and we just come up with a shared decision making to what to use. I don't think there is enough data to allow you in the clinic to tell a patient that I think that drug A is superior to drug B and that you should be on drug A as compared to drug B. We're not there yet. I am hopeful that in the next few years, we're going to develop some evidence that shows us which drug has a more favorable profile. It's just, as you well aware, it's very hard to compare across trials with changing patient population. But I also would be interested to hear your thoughts about this.
I would be delighted to provide them. As you know, I have an opinion about everything. And I totally agree with you. In a way, it's a gift that the clinical trial populations have evolved to become healthier and healthier and healthier over the last 15 years of trial enrollment because of early diagnosis and better heart failure therapies. So as a community, we've all done a great job. But it means you can't compare trials head to head. It's apples and oranges. So you have to do with the data what you can do. So for me, I say, okay, if you have neuropathy, particularly with the variant form, there's good data for the silencer vutrisiran, and now there's data for the cardiomyopathy as well. So Helios A, Helios B. So I will put that patient, I'll say, you know what, I think a subcutaneous injection administered at a healthcare facility every 3 months, vutrisiran is the right thing for you because it should help reduce the progression of everything you've got. If they don't, then I might say, is something cheaper based on your payer plan? I haven't seen car votes happening much yet, but if that were the case, I'd say close your eyes and pick the cheapest one because when three things are medically equivalent, cheaper is always better. And if there is no cost difference, then I would say, what do you think? Do you prefer pills? Do you prefer a subcutaneous injection at a healthcare facility every 3 months? We can work with you on that. So that's the stepwise approach I've used. Now, when the patient comes back at me and says, well, more's got to be better than less. I want everything. Give me a stabilizer. Give me a silencer. I want it all. And I sometimes in that situation say, yes, there is no clear evidence of benefit just because the clinical trials don't allow us to elucidate a benefit through subgroup analyses. There's no harm, but there's two different thresholds here. Evidence of benefit is a different threshold than absence of harm. And there might not be harm to you to take both pills, or both infusion and pills, but whoa, the healthcare system's sure going to feel the effect of that cost differential. So I, of course, would never withhold a therapy from someone because I'll just go next door and get it from someone else. But I do counsel them and warn them that their insurance company at some point may get wise to the fact that there's no clear evidence of benefit of combination therapy, so they should be prepared at some point to pick one. So that's my take on the landscape. Tell me how you approach that patient.
Yeah, totally agree. I think it's very well said. I don't have much to add except for the fact that, I think these practices of layering things on top of each other in the absence of really reasonably strong evidence for it is exactly why we get restricted as physicians from using medications. And, even though we always fight and say, no one should have an input into our decision making when we're with the patient, I think this is a clear example of where I see a future if the evidence continues to be weak or actually non-existent almost. I see a future where we're going to be restricted and we're going to be told what we can and cannot do. And so, it's naive to think that, but in an ideal scenario, we wouldn't do things without evidence of benefit for them because we're going to be told then what we can and cannot do. So, we'll see if the next few years we're awaiting, for example, CardioTransform, as you know. 1,500 patients, lots of them were on stabilizer, probably lots of them were not, and so that might be provide us some more data. But until then, I think as you well stated, there is no evidence that we should be layering these medications on top of each other.
Amazing. When we agree, we must both be right. And we have about 40 seconds left. So I'm going to give you a speed question. I want you to predict the future. TTR depleters that suck the TTR out of tissues. We see some evidence on imaging surrogate endpoints that they reverse disease. We see some evidence with some biomarkers that they reverse disease. Do you think, predict the future, 2028, 2029, when Cleopatra and the other trial comes out, deplete TTR, positive, negative, are these meds going to save lives?
Oh, that's a tough question. I don't know if I can predict. I do believe that there is a clear therapeutic role and hypothesis for the approach, and I think that the therapeutic hypothesis is sound. What I think, hopefully the studies are positive. What I think is going to probably happen is that you'll end up identifying subgroups of the most benefit because the patient population is very heterogeneous, and we right now are approaching them as if they're a homogeneous group. And I think we're going to end up finding out that they're not necessarily a homogeneous group. But this will be the first step in what I expect to be a very, very long line of investigation over the next decade with better and better and improved drugs over time. I do believe that even if it's not in 2028, 2029, I do believe that this is something that's going to happen sooner or later.
I want to thank
you.
Oh, I want to thank you, Dr. Kittleson and Dr. Masri, for participating in this discussion, and thank you everyone for joining us. Final last words, Dr. Kittleson?
I couldn't think of a better partner in crime. I learned so much.
Wonderful. Thank you all for joining us, and thank you for sharing your expertise, Dr. Masri and Dr. Kittleson.
Thank you all.